If the patient happens to land up in some sort of macrovascular complications, suppose this patient is having some sort of cardiovascular disease, then this patient might be having exertional dyspnea, chest pain, chest heaviness, or if the patient is having peripheral vascular disease. And please remember, India is one of the few countries where the chances of developing peripheral vascular disease in a more aggressive pattern at an earlier age is more common. And these patients might be having some sort of pain, some sort of gnawing sensation in the calf muscles, and which becomes easier if the patient takes some rest. And finally, one of the deadly complications of diabetes mellitus, that is the diabetic foot ulcer, that might lead into an amputation. So the patient initially notices a blister or a barnacle, which finally breaks away, leading to the development of an ulcer. And if the patient is not treated on an emergent basis, he or she is likely to land up in some sort of amputation of the finger or of the feet, depending on the severity of the condition. So how do we tackle this condition, this deadly complication? And please remember, the diabetes mellitus doesn't come alone. It is likely to come armed with hypertension, armed with dyslipidemia, or with hyperuricemia, or with cardiovascular disease, or with non-alcoholic fatty liver disease, and a plethora of other health complications which a diabetic patient needs to endure, which the diabetic patient is likely to face throughout the lifespan. So how do we tackle this deadly menace? So first of all, starting with the guidelines promulgated by the American Diabetes Association or European Association of Study of Diabetes, diet and lifestyle modifications are of paramount importance and probably forms the cornerstone of treatment. So the changes in diet I've already mentioned a few minutes back, and about the lifestyle modifications, that is also discussed. So starting directly with the management and the treatment of diabetes mellitus, so metformin, even in 2019, forms the foundation stone or the main backbone of the treatment in a diabetic patient in optimum basis. And if the patient fails to get a blood sugars control, on an optimum dosage of metformin. And please remember, before starting metformin, we should be careful about the renal status of the patient. If the patient is having a compromised renal profile, if the eGFR is already denounced, we need to be cautious about the starting dose of metformin. In these patients, we need to go slow, build up slow, and always keep an eye on the mal effects of the loading of metformin in the system. Let's consider that the patient is having a normal creatinine, a patient is having a normal renal profile. So in spite of the optimized dosage of metformin, the patient is having a blood glucose level well outside the normal range laid down by the ADA or the EASD guidelines. What are our options? So we have a plethora of oral hypoglycemic agents at our disposal. We can use SGLT2 inhibitors, we can use DPP4 inhibitors, we can use thiazolidine, namely pioglitazone, available in the market. We can use a sulfonylurea, and finally some of the costlier items, although they are of immense use, although they have a robust performance in regards to decreasing the blood glucose and also having a documented cardiovascular safety, we have GLP-1 analogs. And in spite of the optimized dosage of at least 3 oral hypoglycemic agents, if the patient still has uncontrolled blood glucose, the patient is bound to require some sort of insulin shots. So we can start with the basal insulin, and if the postprandial blood glucose still fails to get controlled, we can escalate the number of insulin shots. We can add a prandial insulin before the meals, starting with the major meal, and as the requirement increases, we can add prandial insulins before the dinner or before the breakfast. So in spite of the best of the treatment, in spite of the best of the compliance of the patients, please remember, some patients are likely to have frequent peaks and troughs in the diabetic management. So these patients have sudden undocumented hypoglycemias, and the CGMS data shows this patient is having frequent episodes of hyperglycemia. So how do we tackle these patients? So these patients need to be counseled. The diabetes mellitus is a chronic disease, and your compliance is of paramount importance, and probably sticking to a regular meal plan, sticking to a regular exercise plan, and sticking to the medications advised to the doctors. And if required, the patient should have a CGMS data obtained every 6 months to 9 months to have an idea about the control of blood glucose in the body, because not always the blood glucose profile in the patient is reflected adequately by the fasting and the postprandial blood glucose and the A1C data. The CGMS data is also sometimes becoming very, very relevant and of immense significance to the patient. So, my advice to the patients living with diabetes mellitus would be that please remember that having diabetes doesn't mean that it's the end of the world. You can have a lifestyle, an active lifestyle, just like your non-diabetic counterparts. There's no restrictions on it, provided you follow a healthy meal plan, you follow a definite exercise plan, and stick to the advice given by your physician, and take your medications, pop your pills at the right time, acquire a healthy lifestyle comprising of some sort of yoga or meditation if possible. And some of the myths in diabetes mellitus are that once you develop diabetes mellitus, you are bound to cut off all sort of sweetened products. You would be deprived of any sort of sweet intake, but that is not always true. So after at least once a month, if your blood glucose is well within normal limits, and if you can cut down the other carbohydrate intake, then it becomes no problem that if you consume some sort of sweets during a festival. And some other myths regarding diabetes mellitus is that is not always a dangerous disease. But please remember that the diabetes, if it's controlled, is not dangerous. But if the disease is not attached much importance, if the patient doesn't get a regular follow-up, then he or she is likely to develop, is bound to develop some sort of life-threatening complications in the form of cardiovascular disease, like an episode of myocardial infarction or a cerebrovascular disease precipitating in an episode of stroke. So, a patient should be careful if he has acquired diabetes mellitus. And finally, those patients who have developed diabetes mellitus, please don't lose hope, because once you develop diabetes mellitus, I completely understand you are bound to develop some sort of depression, you are bound to develop some sort of anxiety, but please remember that this depression and anxiety actually does more harm than good, because it results in a vicious cycle where there is worsening of the diabetic status due to your anxiety and depression leading to a surge in adrenaline. So, stay healthy, keep an eye on your glycemic parameters, have a regular visit with your consulting physicians, and stay happy. Thank you for patient hearing.